Rob Chapanelli,
Here.
David Kader. I didn't see him yet. Evan Eiler,
Here.
Gail Falk,
Here.
Rachel Gades.
She signed in and she said she's finishing something up.
Yeah, but I think she's on the call.
She is. Yep.
Matt Greenberg,
Present.
Peter Ireland,
Here.
Suzanne Jones,
Here.
Pat King,
Here.
Stephanie Lorenz,
Here.
Ian Odeji,
Yeah.
Don Philibert.
Here.
Is Judy Scott here?
Yes, I am.
Great. Margaret Tando.
Here.
Oh, fantastic. Bob Tortolani,
Here.
Scott Tucker,
Here.
Megan Campbell,
Here.
Kurt Kuehl,
Present.
Bill Reynolds,
Here.
Justin Chang.
He is not here, but I am filling in for him today. I'm Laura
Okay.
Ashikaga. I'm the other AAG for health.
Oh, is that you, Laura?
Yep, that's me.
Oh, fantastic. Okay. Let me mark you present. Lauren Lehman. Nope. Scott Frenier.
I'm here.
Tracy Hayes. Nope. David
Here.
Herlihy. Oh, here. David Herlihy.
Here.
Paula Nenninger.
Here.
Marcy Quinlan.
Here.
And is Jessup Bernard here?
I don't see her.
I
See her.
thought her signed on at one point.
Are there
Yeah,
any
same.
other guests that want to make themselves known? No. Great.
Great.
Is there any public comment? Hearing none, we can move on to the approval of the minutes from the February 4th meeting. And if you all have had a chance to review those, I'll entertain a motion to approve.
So move, Philibert.
Can I get a second?
Second, King.
Great. Any discussion? All those in
Just for
favor?
the
please say
record,
aye.
it was February 5.
Did I not say that?
You said 4, but
Sorry, February 5th, 2025. All right. All those in favor, please say aye.
Aye.
Any opposed? Abstentions or recusals? Great. As for board issues, so two things I was just going to bring up here. One being there's been a lot of discussions in email around signing up for a login.gov account. For those of you who have not been following your emails, you do need to sign up for a login.gov account. It took me all of 2 minutes. It really shouldn't take very long. What I didn't know, David, and maybe you or someone else could just clarify this. Do we need to do anything other than sign up for an account? Is there any linking that we need to do or anything like that?
I'm not aware of anything. I think, that the communication that we got makes it sound like beginning tomorrow that your only option to get in will be using the login.gov. I don't know if that was just trying to create a sense of urgency to get people to do it in advance of the actual date when they flip the switch, but more to follow. I did, there was. And it was weird because David Kodar got a message that was different from others. And I don't know if anybody else got that same message that had a line in it that said something about if you've signed in since November 21st, you don't need to do anything now.
Right.
You're set. And I emailed Ron LaFond. For those of you who remember Karen's husband is the director of the Vermont Fusion Center. And he said, yes, indeed, he is the official representative of Vermont to his end overall, and he said, indeed, you do need to do this. So
Even if we've signed in since November, like I signed in this morning and had no problem.
He said that was an error, and according to their emails, that there's not going to be any problem before March 6th. So today is the 5th, and so
Okay.
But I've gotten several people have asked me, well, is it not going to work tomorrow if using our regular sign in? I don't know. I can't guarantee that. That's what they said.
Mhm. Okay.
So we'll, and I will echo, what Rick said. And I realize that for others maybe don't have all the access that Rick and I have, but I signed in. It took I think it took me 10 minutes, but I had a lot of interruptions and got pulled away from
Some time.
doing it. It took a couple minutes to upload one thing, but other than that, it was not tremendously hard. One thing that has hung some people up, they recommend using 2 different means of verifying your identity. That's not a requirement though. So if you only have a smartphone and don't want to get an authenticator app, then you can use your smartphone as your second source of verification.
So
we have
David, I
number
have an
of hands.
authenticator app that I use for the South Burlington Development Review Board. Is that the same app?
I think they accept a lot of different ones, I think
should work.
if it's,
Okay.
and I mean, I added the authenticator app and we have one that we already need to use to get into our devices within the health department. And it just, all of a sudden,
Okay.
I said that I wanted to use that one from a list and it showed up on my authenticator app that his was one of the users of that
Okay.
app.
Great.
So,
All right, we have a bunch of hands raised. Gail.
So I was able to get, do the login, but I couldn't see how to get from the login to HISN. Is that not yet available? Is that what's happening on the 6th?
Well, yeah, I'm not sure if the landing screen is going to change so that it asks you, to redirects you to login.gov.
We don't know.
I use a lot of different federal sites and I use there's another one called ID.me.
Yep.
is another verification service that the federal government uses. And it redirects me when I go to whatever the site is I'm using. It just says, okay, you're going to be verified by ID.me, and then it brings you right back. So I don't know what it's going to look like.
I thought ID.me was public sector actually, but it doesn't matter.
Yeah,
We don't know.
but it's
the
used.
answer.
It's a commercial one that's also used
Yeah.
by the government.
Yeah.
So what I will do is I'll keep on checking, trying to go in using the old school way of getting in. And when it doesn't work, or if I find something has changed, I'll send out an email to everybody alerting you.
Okay, a bunch of people lowered their hand. I'm going to go to Ron. Oh, wait.
I sorry, I got an email yesterday. I don't know if you all got it. If not, I can forward it to the group. It says it's from HISN to prepare for your transition to SSR, which is just the new self-service registration. You must complete the following 2 tasks: logged into your account since November, and number 2 is create a secure account. So as of yesterday, this email is saying we need both of those.
Okay.
Yeah, and if anybody's having issues, feel free to reach out to me as well. Happy to help.
Sorry, Judy. I didn't mean to skip over you. Judy.
No, that's fine. I have an authenticator app, but when I try to use it, it's one of the ones that they list and say can be used, but it didn't send me a code. And the screen wouldn't let me continue without entering a code from my authenticator app. So I got stuck there. But I just wanted to let you all know that I have an additional problem because I have just gone in to renew my driver's license. So I have a temporary license, and that cannot be accepted as a means of identification. It's taking quite a while to get the physical license in the mail. So I could go without my authenticator app and just use one method of authentication. But I will not be able to get in until I get my driver's license.
Did your driver's license already expired?
Yes,
Yeah, I don't know. I mean, I don't know if there's a grace period where they might accept the expired driver's license. I mean, your driver's license number wouldn't change, but I don't know if you wanted to try it or if that would just cause a problem if you had one in the system that was expired, but.
well, you have to send them a picture of it. And
Right.
I'm embarrassed to tell you how long my driver's license had been expired before
Okay.
I realized it and went in and renewed it.
Oh,
It is
okay.
just a couple days.
All right. Well, so Judy, you and Ron can connect. If need be, what we can do is get you a package of the new things that are you would need for the North Committee. We used to do that old school with everything. People constantly got big thick envelopes. We can do that as a workaround maybe, or Ron can talk about other workarounds, but we'll figure it out.
Well, I would appreciate that. I've tried to get up to date knowing that this was going to happen tomorrow, but things often come in the week before the
Right.
meeting.
Yeah.
So that would be great if we could do that.
We won't leave you in the dark.
Thank you.
All right, and Stephanie.
I have a similar problem that as Judy had. I went through and I almost got finished with it, and I put my phone number in, and they said they could not verify my phone number, and I've had it since, I don't know, 20 years ago. And so they and I tried a couple of times, and they said, no, we're not going to take it. You have to get something by mail. So request a letter by mail and it'll take 5 or 10 days. Well, the 10 days may be beyond the South Committee meeting. So I don't know that I'll have the ability to get in to look at the documents.
Hey,
If-
we'll.
Go ahead.
I was just gonna say, we'll connect you with Ron too, Stephanie, and
Okay.
we'll try to address that problem and also talk about workarounds if needed.
Okay, thank you.
And Scott.
Yeah, I already had an account, but it still made me do a letter because it couldn't verify my number. But it didn't take the 9 days, so I'm guessing you'll get it back and then you'll be able to complete the process. But so the purpose that I'm on there already has a link to that. So my guess is we'll receive the link in due time.
Okay, thanks. I hope so.
Evan.
How close are we to our new system?
The projected go live date is March of 2026.
But that
Okay.
doesn't change HISN, does it?
Yes, it will. It may not, the day we go live, we may not, be flipping the switch to go away from HISN and distribute through the new system. But that will be when we're able to start setting up the new system to provide access. And it's our belief and our hope that we will be able to start to provide you access and use permissions to manage the process. So
Not to get too much in the weeds, but how are we going to authenticate users? I mean, that's what I mean. The HISN is a double-edged sword. It's a pain in the butt, but it's a great, secure method for authentication.
yeah, and you bring up a good point, Rick. We may find the login.gov may resolve a lot of the headaches we have in access for members, which may, we could revisit that decision about are we going to go to managing this system? It still would mean if we can do it through the new system, that would mean that Kelly won't have to run a parallel communication system for you all. So.
Okay.
So.
Peter, did you have a comment or?
I was just wondering if the board kept local backups on files in case there were, for some reason, issues with a government website.
Well,
We should do that.
everything at Hizen is a duplicate because it's running in parallel. We don't rely on that internally. It's a sharing platform for us to get it to. Just the history on this is we've never been able to allow members to have accounts to get into the state run servers or systems. So, I've been.
I think we lost David.
You lost me?
Oh, now I hear you.
No, we don't.
Nope.
You're coming and going. It's weird. What I heard was we can't get access to the local state servers. Again, likely a security issue is my guess, but so we access the public domain. Is that right, David?
Yeah, yes, that's the short story. It's my understanding that we will be able to, there's a pathway that we can pursue in this new world we're going to, but we'll cross that bridge when we get to it.
Okay. So please make sure you create an account. If you have issues, talk to Ron. We do not know what's going to happen tomorrow, but there may be an inability to log into Hizen if we don't have a login.gov account. Regardless, just try and get the things done so we can make sure there's as little hitches as possible. Any other discussion or questions on this topic? No. The only other thing I had was that I had the opportunity to speak to the Senate Ops Committee the other week, discussing I forget the number, it's S64 maybe, the optometrists doing
64.
surgery bill.
Yes.
That was a fun experience. I think David's assessment that he had relayed in the past is very much accurate. The committee seems to have, at least some members of the committee seem to have their minds made up. I don't know, they seem to be on, at least again, some members seem to be under the impression that if you ask enough times, someone should change their mind. I don't really understand that logic, but that seems to be the belief. I did do a fair amount of sort of research just to have a cohesive statement to make. And again, I think it was a waste of time because I don't think they really seem to care very much. But anyway, we'll see what happens. This is just one committee. It may go other places like House Healthcare or other places before it ever goes to pass. Dawn.
So the ophthalmologists have done a good job of promoting their opposition to this by putting banners on a lot of websites.
Okay, great. I was very transparent in my sort of statement that if there were evidence that we should review, we would love to review evidence that this is a good idea. There just isn't any out there. And I did get a response email from an optometrist who I happen to know personally, who was in the committee and is the president of the Optometry Association, which is always fun. I don't know, Suzanne, if you know Tina, but she's a good person, and she tried to provide some research that actually didn't really help her case. But anyway, if there ever is information, I'm sure we would be happy to review it. It just, there hasn't been any published research or information that I think would materially change the discussion.
Yeah. I mean, Rick, the point Rick brings up is that they're relying on a perceived lack of information about complaints or reported problems. Yeah. And Rick said that's not the same thing as a study that shows that the outcomes are as efficacious or that the right. Safety is the same.
Right.
I'll touch on it a little bit more during my legislative update. Yeah.
Great. That is all. Oh, sorry, Ron.
Yeah, just wanted to double check. now that we're in tax season, if anybody has not received their 1099 for their stipends, please let me know. We can resend it to you.
Oh, okay.
I'll have to check. My wife just submitted those all. I hope she included that 1099. Thanks for reminding us. All right. David, administrative update. Take it away.
Sure. You stole my thunder with the login.gov
Sorry.
issue. Thank you. So we'll skip that. One other thing I just wanted to mention was there was a little bit of confusion about the numbers that we put out last time, and the PA numbers were off. And I just wanted to explain that the numbers are confusing in one respect because I sent out an email a week after the last meeting on the 12th. I don't know if everybody saw it. The PA renewal straddles the first of the year. And so in the past, a decision had been made often to do the numbers on a fiscal year basis, which resolves that, so that we'd be reporting from numbers from July 1st to June 30th. But in the real world, like annual reports and things, people think in terms of years. And so I had made the decision that we were going to go with reporting years. So you have to add together, when you see the PA numbers, you have to add together the both years with an understanding of which set of years go together if you have a table with multiple years. And anyway, the good news is the PA numbers are up. They're not declining. They're up significantly. And that was all I wanted to add about the numbers. Rick, question?
Would it be clearer if we just lumped 2-year cycles together and had a 22-23 and a 24-25 and a 26-27, just because of that issue with the straddling? I don't know if that helps or hurts, David, but knowing that we're on a 2-year cycle.
Yeah, Ron and I can kick it around some
I don't
more.
know. Not to do more work. I just.
Yeah, it depends on kind of the purpose. You know, we're always trying to figure out the best way to identify trends,
Right.
which is really what we care about. You know, because if there's if there's a good trend, is there something that we need to keep doing? If there's a bad trend, is there something we can do to address it? But we'll look at that some more.
Anyway, just not for now. Like, this is done. We got great data. We appreciate it. The numbers are up, but if next go around, it might be helpful to just make sure we're looking at what we think we're looking at. If that helps, if great. If it doesn't, then don't ignore what I just said.
Okay. And I didn't have any other admin issues. Is Tracy still on the call? Tracy, are we all good for expense submissions?
Well, we're missing quite a few of them. And if you don't think you've submitted through December, you can reach out to me and I'd be happy to let you know who you are. But we do need to get those all done. So because Marcy has started in January counting those, but I need your December ones first, please.
So, okay. Thanks, Tracy. So, Rick, we do have the hearing on for 1 o'clock. So we got a good amount of time before then. So with your permission, I could move on to the legislative update.
That sounds great.
So there's just 2 bills that we've spent a substantial amount of time on. The first is S28, and that was voted out by the Senate Health and Welfare Committee with some amendments. This is the bill that it also relates to the lawsuit that the board is among the state defendants on. It has to do with the provisions that were passed a year ago about the legally protected health care and gender affirming care. And so there's good news and bad news about what came out of Senate Health and Welfare. I'll go with good news first. The good news is it includes a provision allowing us to withhold the personal addresses, telephone number, and email of all applicants and licensees. So that's really good. It's really been a frustration for us, and especially as sort of there's more and more signs of potential threats to people when their information gets out there, and so I think this is good, and this came up I met with a number of stakeholders, VMS and the Hospital Association and some others, and there's talk about this, and we all came to agreement, and the committee was amenable to a suggestion to add this, and so we'll see if that goes through. Some other good news about the bill is it does revise the language that's in the law currently that resulted in the lawsuit. And if you all recall, that had to do with limited service pregnancy centers. And by limited service, it means pregnancy service centers that do not offer abortion. What they offer is counseling about pregnancy, and they offer, in some instances, sonograms to show the individual fetus. And so what happened when they passed the laws about the legally protected healthcare activity was they expanded the Vermont consumer protection laws to include just limited service pregnancy centers. And for any other service that isn't at a fee or service or product that is not paid for, the consumer protection laws did not apply. And one of the things that made an issue and resulted in the lawsuit and makes for a legal issue for the Attorney General's office in defending the law is that they were singled out. And so in this proposed revision, they are expanding the consumer protection law to say, you know what, with healthcare in general, it doesn't matter if there's a payment or not. With regard to any advertising for healthcare, if there is communication that is untrue or clearly designed to mislead the public about the nature of the services provided, then that's a violation of the consumer protection laws. And I think that we support that, and we might be able to use that to help us in some of the instances where we've had a concern about deceptive advertising. And so I think that's good. Another improvement that's in the version that came out of Senate Health and Welfare was a change in the provisions that apply to unprofessional conduct. And in discussions about the bill, again, this is the same group I met with that proposed protecting the personal contact information of licensees. And the provisions in our unprofessional conduct definition that address letting your name or license be used to allow medical services to be provided. That language was revised a little bit, and so it now includes the concept of active oversight. Talks about actively overseeing treatment given or other healthcare services provided. So that's a subtle but maybe helpful improvement when we encounter these cases where somebody is allowing their name to be used. They're designated as the medical director, but maybe not really doing anything. And the law that defines unprofessional conduct was also revised. in the subsection that applies to delegation of professional responsibilities. And it says, they added the phrase, including delivery of any healthcare services, which has a fairly broad definition. And also in the part that said that when you delegate, it's a problem, it's unprofessional conduct when you delegate to a person whom the licensed professional knows or has reason to know is not qualified by training, experience, education, or licensing credentials. And that would allow having anything. It was an or in there, and it would allow someone who would, arguably, and we've kind of seen this in some of the investigations we've had, where they'd be like, well, this person had a 4-hour seminar, and here's the training certificate from the company that said that they're qualified to do this. And so that's been changed again subtly to say is not qualified by any combination of training, experience, education, or licensing credentials. So arguably now it would require, to have a combination, you would have to have at least 2 of those. So it's a little bit more. It was really, we talked quite a bit about this. Coming up with something, because you need to account for the fact that you could have you could have a brand new PA who didn't necessarily have experience doing something. You can't make it all. You need that, or for anybody for that matter, it doesn't have to be a PA, for anybody who might reasonably be delegated something. There's always going to be a first time, so they may not have experience. So again, I don't know how much it's going to help, but that was what came out of the committee. And now I'll turn to the bad news is, despite presentation of the position that this board took last month, saying that you believed it was important for quality care to not allow prescribing by questionnaire only, the committee decided to include the exception for use of a questionnaire only, with regard only to medication to terminate a pregnancy. So that's, again, it's what came out of, it was voted out of the committee 4-1. There's one member of the committee disagreed and didn't support it. And I believe, based on a hallway conversation, that was an important part of it. I felt like this was very much an outcome. It didn't matter what we said, it was the outcome that was desired. And my understanding is that there are organizations that have built systems for providing services to pregnant women who want to get prescriptions for termination of a pregnancy, and those systems are designed around just a questionnaire that doesn't require communication. And and so they wanted to conform, I believe, to allow Vermont prescribers to participate in those platforms. And this isn't the end of the discussion. The bill will go on to some other committees and probably and certainly will go on to be considered in the House, and we have a chance to present your position again. So that's S28 and S64.
David,
Yes.
Evan has his hand raised.
Oh, sorry, Evan.
Just a quick question. I mean, all of this is really super interesting. Am I understanding it correctly that, say that you are the medical director of a clinic and someone says, hey, we need more of this kind of service, get Evan Eiler to do it. And you say, well, there's this piece of paper and there's these other things, but in my best judgment, that would be a bad idea because Evan Eiler isn't really qualified to do that, that you have some protection in that regard. Is that what that's basically doing?
No. So Evan, what this is trying to prevent is these for-profit companies who basically buy the licenses of individuals so that they can provide a whole bunch of medical services by untrained people. So whether it's a Medi Spa or some other thing that has, maybe an LNA, maybe not even, but it has medical oversight by a medical director who's never stepped foot in the place, never met these people, never talked to a patient, and
Oh,
somehow
I
that's
understand. I mean,
Yeah.
we're trying to rein in the vitamin infusion spa license
Yeah.
for Lillian thing, but my question was like, how far does this go? Does it also give protection to people who are in smaller settings, or is it really aimed only at these macro situations? Which is good. The fewer of these weird spas, the better.
I think, Evan, that it could apply in a lot of different situations. But I think the standard, it's knows or has reason to know. So is not qualified. So, if I guess, the easy one is, if it's within the person's scope of practice, absent like knowledge, if you knew that somebody had just was like completely
Terrible.
incompetent, then you shouldn't. If we could use that if somebody, they knew that 5 patients had been injured and this person just was not able to do something. I mean, it could be something as easy as a phlebotomist taking a blood draw that kept on harming patients. But the I think I hear what you're saying. And it's never good to, it doesn't make you feel warm and fuzzy when you say, well, trust us, we're not going to misuse this I don't think, we have no interest in going after. Yeah.
The intent is the macro and we'll see what happens from there. Okay.
Yeah.
Thank you.
Any other questions on S28 before I move on? Right. We already talked about S64, so just a little bit more of the story. So, and we have some new members, and we hadn't really talked about this yet. So I just want to give a little background. The board has seen this a few times over the past several years, and Rick sort of previewed what I'm going to say, saying that if you keep on asking, that their theory is if you keep on asking, maybe it'll change, and that's they're not giving up.
Like kids.
They're attempting to expand their scope of practice to allow them to conduct a number of surgical, a number of interventions that constitute surgery. And that, they describe them as advanced procedures, or, and they probably, they want to talk about them as minor things, whatever. They are, whether injections or using a scalpel, or if some of them a laser, they constitute surgical interventions on the eye and the is it axilla? Is that the right term, Rick? The surrounding tissues, and the board, VMS, and the Ophthalmology Association have consistently opposed this. And when when this first came up, OPR did a report and said, no, we don't think there's a basis for doing this. And then they kept on trying, and it came up several times in the Senate Government Operations Committee. And finally, the Senate Government Operations Committee sent a letter to OPR saying, it was in 22 or 23, they wrote to them and said, do the report again. And we basically decided this should happen. Give us what we want and give us a give us that's my summary of it, but, and give us a proposed statutory framework for how this would happen. And, so they came back with a report, and shockingly enough, they said, oh, well, yeah, we think there's enough now. And gave them a framework for how this could happen. The background is it has happened in about 10 states nationally. I think the number may actually be 10 now. Oklahoma was the first, and that happened I think it was in 1998 they did it. And a handful of other states did it in the years that followed, maybe in the early 2000s or say before 2010. And then a number have done it just in the last few years, or maybe 5 or fewer. And so our take on this is that there's a number of problems why a state should not jump into this yet. There's a lack of evidence that there's a problem of access to ophthalmological services. There's evidence of access issues with basic optometry services. And there's been plenty, it's been anecdotal, but there's been plenty of testimony and that's been unrefuted of long wait times to get appointments just to see an optometrist to get a routine exam and eyeglass prescription. There's no evidence of cost savings. Procedures are billed based on the procedure, not the licensure of the individual performing it. The states that have done this in general are they're larger in terms of square mileage. They tend to have low populations, like Vermont, though California, I think, has done some of it. But there's just not a lot of data out there because of their small populations. They had greater reasons for doing it, and they had issues with access to ophthalmological care. Optometrists were closer to some parts of the population. So, we can continue this came out of Senate Government Operations. It's going to, they did vote it 5-0 out, and no shock there. And it has been referred to Senate Health and Welfare, and hopefully Senate Health and Welfare will pay more attention to the discussion about the safety to patients, and hopefully they will be better equipped to understand, like what Rick was presenting about the difference between a lack of evidence by virtue of malpractice cases or negative information versus a study of what the quality is when you're relying on optometrists. And we'll see how that goes, right? And just one other thing, I had a note here to remind myself what it takes if you graduated from optometry school in 2019 or later under the bill, because they do little modules about doing these things in optometry school. It requires a 32-hour course on doing these procedures, and there's quite a few of them. There's a number of different procedures, and a short test to be able to do it. And I've heard Dr. McNally, who's an ophthalmologist who works for UVM Ophthalmology out of their Berlin office, gives very compelling testimony about doing these and about how delicate the procedures can be. And and Rick made some great points about, if you have an optometrist doing these things, they may come across them, here and there, but they're never going to really have the volume that the cases are being referred to the ophthalmologist now. And so ophthalmologists see these things on a regular basis and really have a chance to develop expertise in doing them. And something else that we've heard from Dr. McNally and other ophthalmologists who testified is that ophthalmologists will tell you that they get patients referred for some of these procedures, but for various reasons, the ophthalmologist decides the procedure should not be done. And, you know, again, that's something that's not going to be caught in the data that they're talking about, a lack of evidence of malpractice cases against optometrists for messing these up. That's not going to be caught. Like, how many patients are going to undergo procedures that present potential additional risks and just are not needed, and it's you know, the opposite of cost savings. It's adding cost to have these additional procedures. So we'll continue to work on this one. The fight is not over. So that's all I had on the legislative update. There's a number of other bills that I'm continuing to follow, but nothing that I was going to spend meeting time on today to go over. So
Dawn has her hand raised.
David, given that the medical practice board could be seen as biased because they're protecting their turf, do you think it would help for a public member to testify in front of Senate Health and Welfare?
Sure, I would love it if we could have. I mean, Rick did a great job.
I'm sure.
If I can talk him into doing the same for in Senate Health and Welfare or in the House, but if you wanted to add another voice, just as you know, somebody who's a public member and has background in public health, that would be great.
Right. Okay. And let's not forget that the chair of the Senate Health and Welfare Committee is married to a physician. So, and is a scientist herself.
And I did that question specifically, Dawn, did come up about the finances of this. And I said, finances never came into any of our deliberations around this. And B, we don't have an ophthalmologist. And if we did, I would ask them to recuse from the conversation.
Sure.
Because it would be perceived conflict of interest.
Sure.
And I tried to make that very clear because it's
Okay, I'm sure you did. Yeah.
certainly something important to me. I mean, we were talking about quality and serving the people of Vermont, not anything else, which of course there's
Right.
another side to this coin, which is entirely why this is coming up. It's all
Sure.
financially driven. We know that.
Right.
Pat,
As scope
sorry.
creep often is.
You know, just on those issues, it's funny. You know, well, we on the one hand we do say, and the evidence is that ophthalmologists are really busy in Vermont, but they whenever there's something that has any level of urgency, they get somebody in right away.
Mm-hmm.
And that's what, you know, they've testified to, but none of them are lacking for they're not looking for business. They're very busy. I mean,
Right.
so
Yeah. Pat,
Yes, just a question and a comment maybe. Should this become the law and that the optometrists are able to do these procedures, since they are surgical procedures and the same as ophthalmologists perform, what about the regulation? And, you know, it's just like all scope of practice, we are concerned about who's actually following up with the regulation. And I think for the nurses, there's a physician on the nursing board for reviewing NPs, but it's really an issue. If it's same, and it should be, you know, adjudicated same.
right. Yeah, with this, it's not exactly the same, but this bill includes a provision that would impose a reporting requirement to report out the results of procedures. So
that's not the same.
that may be helpful. I mean, you know, if we are concerned about that, we could we could access those reports periodically and see, but that's, when that starts to happen, there can be discussion about how to deal with that, or in advance. If this passes, there'll be a period when it's being implemented, and we can talk about ways to try and monitor it. I don't. Yeah, I mean, we could ask for them to add that if it appears and that if it passes in the Senate and things look bad in the House, we could ask them to add a similar provision to call for a member of the medical board to be, designated as to be brought in for any cases involving these surgical procedures, or a designee of the medical board. We could try and recruit a ophthalmologist to be part of the review. Because you're right, Pat. I mean, you want people who have a fair level of expertise, and there's probably a lot of people on the optometry board who went to school, graduated prior to 2019 when this wasn't even taught in school.
Yeah.
Is there any other surgeries that are overseen by a board other than ours except for dentistry?
No, just the DOs, obviously.
Yeah, obviously, right. So the DO board and our board, it's sort of a little uncomfortable to have surgical procedures to be overseen by a board who doesn't regularly oversee individuals who perform surgical procedures.
Right.
That's my only point. So I think Pat's comment is spot on. If it appears as though this is going to go not the way we hope it will, anyway.
Yeah. So,
Ian.
So I just have three. I just have three quick questions. Do we know the specific procedures they are trying to perform?
There's a list in the bill, and I can send out, if you want, I can send an email with a link to go to the bill. And one other thing I wanted to mention, if anybody's interested in seeing the meetings where these things were discussed, if you go to I'll send a link to the legislature website, and each committee has its own page, and there's a button on the page to stream, and you can go, each of them has actually a page on YouTube, and you can see the various days when things were discussed, and you can go in and listen to what happened during the meetings and see presentations.
All right. Then in terms of training, where would they be getting the training to do these procedures? Are they going to be training themselves, or who's going to train them to do the procedures? Do we know?
The bill includes it speaks to an experience. It needs to be, there's a mentoring piece also until they've had a certain number, and it needs to be either an experienced optometrist who's experienced in those procedures, or an ophthalmologist.
But the training is not on humans prior to that, Ian. It's a sort of simulation, and it's measured in hours, not weeks or months or years.
Oh wow.
Yeah, and then there's a requirement for them to do, I think it's a total of 12. There's they have to do 2 of this and 1 of that and 2 of this. It's kind of a a la carte menu.
Not 110 and 75, which is what it is for ophthalmology residency.
Wow. Then the last question: in other states where optometrists are performing these procedures, have we seen any adverse effects with them doing it, or do we know?
So that's
Go ahead.
that's where a lot of this discussion went. Ian, there is no published articles that show non-inferiority, which I would expect the optometry advocacy programs, if there was anything that showed non-inferiority, they would publish that, and that doesn't exist. Are there published things that say there's you can't publish when something doesn't exist, so that we don't know if there's equivalent outcomes or not. And one of their biggest arguments was, well, there hasn't been evidence of bad outcomes. We don't know. There's nothing that really indicates that there's, higher, incidence of bad outcomes versus one versus the other. It just hasn't been studied.
And again, until very recently, this was mostly going on only in Oklahoma. And there was a few very low population states that had gone in that direction. And I think you all know from your experience with the board, how many malpractice cases do we see where, you see them and there was an event in 2023 and there was a settlement in 2024? It doesn't, typically the cases that we're getting now, it was an event in 2013 and a case was filed in 2015 and it's just getting resolved now, or maybe not all that old, but it takes years. So with the greatest number of states have only done this in the last, 5 years or maybe a little bit more than that, but you wouldn't even know that there had been medical malpractice cases yet because they haven't resolved yet in the time frame that this has been happening. So I'll follow up with an email and give you tell you all how you can look at the bills and see the if you want to go and follow the streaming, and when they're scheduled, you can live stream it, or again, you can go back and see it after the fact.
The quote by I couldn't pull this at the moment when they were talking about, but by Carl Sagan is, absence of evidence is not evidence of absence. Right. That's the quote, right? So just because you don't see something doesn't mean it isn't there. Anyway. All right, it is 1 o'clock. I thought I saw George pop in the executive session. Did he?
He did.
Find his way over here?
Yeah,
he did. I just sent him this link. I'm going to message him right now to get him into this one.
Great.
My bad. I'll be right back.
Sure thing. The I don't know when is the right time to bring this up or not, but there was an email that went out like today about this topic. Did you get that, David?
Went out from whom?
From the licensee.
From Ron, the one
yes, Ron forwarded. So
yes,
yeah, there'll be discussion about that.
Okay.
We wanted to make it available to you. That came in last week. The licensee submitted some things,
right?
And I'm sure George and Kurt will be discussing that with you all.
Okay, I just wanted to make sure that seemed to be some misunderstanding by some.
David, do you have a phone number for George?
I do.
He's right there.
I'm right here, David.
There he is.
Oh, fantastic.
Got him. George, welcome. I think we are ready to take up the matter at hand.
Great. Good afternoon, board members. And I see that we're on the record. Just for the record, the date is March 5th, 2025. We're here before the Vermont Board of Medical Practice. We're taking up the matter of Henry Scott W. Smith, MD. The docket number is MPN, as in November 158-0623. I'm going to ask that Ron Hunt call the roll, and that would exclude the North committee members. But as your name is called, as Mr. Hunt calls your name, if you're participating in this matter, you can say present and participating. If you need to recuse or abstain, you can say that as well. So, Mr. Hunt, could you call the roll, please?
Ron, this is Kurt Keel, and in just a moment, but before you start, this is a central case actually, so central members should not be called.
Well, okay. The docket number is MPN, isn't it?
Yeah, I'm afraid, George, I may have had a typo on the notice about the
All right.
hearing, but the respondent is aware of it, and I don't think he was misled by that typo on the notice.
So David, what is the correct docket number, please?
It's C as in Charlie.
All right, thank you. MPC 158-0623. Great. Thank you, Mr. Kuehl, for correcting that. And Mr. Hunt, could you call the roll that would exclude the Central Committee members?
Yes. I'm just making sure I've got the right list here. Jones. Robert Chapinelli?
Present
That's
but
Central.
refusing. Yeah, Central.
Oh, you are Central. Okay, I've got the wrong list here. Oh boy. How about, you know what, I'm just gonna go down the list, and if you are abstaining, you'll let me know. Rick Hildebrandt?
Here.
Chapinelli, Central. David Kader?
I'm here, but I abstain because I'm on Central.
Okay. Evan Eiler?
Here.
Yellow Falk?
I'm here, but I abstain because I'm on Central.
Thank you. Rachel Gades?
I'm here. I'm on Central Committee, so I'm not participating.
Matt Greenberg? Are you Central, Matt?
Yes.
Sorry, my mic was off. Abstaining, I'm on Central.
Got it. Peter Ireland?
Abstaining, Central.
Central, okay. Suzanne Jones?
I'm here and I'm participating.
Pat King?
Present.
Stephanie Lorenz?
Here and participating.
Dr. Odeji?
Present and participating.
Don Philibert?
Here and participating.
Judy Scott?
Present, participating.
Margaret Tando?
Here, I'm on North.
Robert Tortolani?
Here, participating.
Scott Tucker?
I'm here participating.
That's it for board members.
Great. Thank you very much, Mr. Hunt. So I note the appearance of Kurt Kuehl for the state. Is the respondent, is Dr. Smith participating in any fashion?
I don't expect he will be, Your Honor. He has received notice of the hearing, and my conversations with him lead me to believe that he won't be.
Mr. Kuehl, what notice was he given of today's hearing?
The board sent out a notice of hearing, a formal notice of hearing that by Mr. Hunt, yeah.
And have you spoken with Dr. Smith after that notice? In other words, have you gotten word from him that he did not intend to participate today?
No, and not specifically about that. This is just the basic conversations I've had with him led me to believe that. So I can't say affirmatively that he won't be here, but I don't expect him to be.
All right, so we're going to let the record reflect that he's not participating today. And go ahead, Mr. Kuehl, if you want to present this to the board, that would be great.
Okay. Thank you. Yes, as noted, I'll be presenting the state's motion for reciprocal discipline today. And it requests that the board revoke the license of Dr. Scott Smith, order that he be permanently prohibited from applying for or obtaining a Vermont license, and also impose a $2,000 administrative penalty. Now, because this request is being presented through the compact, I wanted to start just with a brief overview of pertinent provisions of the compact to give you a bit of framework for considering the motion. So as you probably know, the compact is essentially an agreement between states that's codified in their statutes, and it provides an expedited pathway for physicians who want to practice in multiple locations to or multiple states to obtain licenses in those states. The compact provides that when a physician is disciplined by one member state, other member states where the physician is licensed under the compact may impose reciprocal discipline based on the action taken by another state, and they can impose the same or lesser discipline as they deem fit, as long as Vermont's statutes permit that. The state can also choose to proceed with formal charges and a contested hearing as another option. However, when deciding to take action based on the other state's action, the compact permits the board to deem the action taken by the other state as conclusive as to the matters of law and fact that it decided. So then the question for this board is not whether the conduct in the other state occurred or whether the discipline imposed by the other state was appropriate, but only whether or what discipline that Vermont wants to impose. So that's a very brief summary, but those are the pertinent provisions that we'll be addressing today. Dr. Smith was first licensed to practice in Vermont in March of 2022. His license was issued through the compact. He is a resident of South Carolina. And in January of 2020, Dr. Smith opened up his own practice in South Carolina, where he operated a family practice clinic. And he also separately treated patients with ketamine for depression and other conditions. After the onset of the pandemic, Dr. Smith transitioned to a telemedicine practice in late 2020. And eventually he became licensed in 48 states, and he closed his family practice and focused solely on providing ketamine treatment for depression via telemedicine. And the board opened this matter in June of 2023 after it received a notification from the National Practitioner Data Bank that Dr. Smith had surrendered his Alabama medical license while he was under investigation by the Alabama board. On May 3rd of 2023, the DEA issued an order to Dr. Smith that immediately suspended his registration to prescribe controlled substances. And a few days later, DEA agents raided and searched his home. The DEA order suspended his prescribing privileges, controlled substances providing privileges, because he constituted an immediate danger to public health or safety. And specifically, the DEA order alleged that between December of 2018 and February of 2023, Dr. Smith issued approximately 2,224 unlawful prescriptions for controlled substances, including ketamine, and in Ohio and 10 other states. And he did that without obtaining valid medical licenses or obtaining and reviewing prescription drug monitoring program databases, information required by those states. Dr. Smith didn't contest the DEA order and instead surrendered his certificate of registration. In June of 23, Dr. Smith voluntarily surrendered his Alabama medical license while he was under investigation. And as a result of him doing that, his Vermont license was automatically suspended as required by the compact. In August of 23, the Medical Board of Ohio issued a notice of hearing to Dr. Smith, notifying him that it intended to take disciplinary action against his Ohio license. The Ohio board alleged that in May of 23, the DEA suspended his registration, as I just discussed, and also that he subsequently suspended his DEA registration. And the Ohio board alleged that both of those actions constituted unprofessional conduct under their statutes. Dr. Smith requested a hearing and attended the hearing. And after the hearing before the Ohio board, the hearing examiner issued a report that included proposed findings of fact, conclusions of law, and recommended sanctions. The board found that, as a finding of fact, that the DEA issued the order that suspended his license, and that based on it suspended his DEA registration in those states that were being investigated. The board also found that when Dr. Smith surrendered his license, he surrendered it for cause based on his failure to comply with federal requirements pertaining to the prescribing of controlled substances. The hearing examiner in that case recommended that Dr. Smith's license be suspended indefinitely, but for not less than 180 days, and that he be assessed a fine of $4,500. In January of 2024, I should say, the Ohio board considered the recommendations from the hearing officer. One member of the board moved to approve the recommendations, and on the vote, that motion failed, and it wasn't approved. Another member then moved to approve the findings, conclusions, and order, but with an amendment that imposed a permanent revocation of Dr. Smith's license. And that motion passed on vote. And thereafter, Dr. Smith appealed the decision of the Ohio board to a court in Ohio. And then subsequently in April of 2024, Dr. Smith withdrew his appeal, dismissed it, and the Ohio order thereby became permanent and effective, I should say. And his license was permanently revoked, and he was assessed a $4,500 fine. So as part of the committee's investigation of this case, it identified 21 patients that Dr. Smith had in Vermont, 21 patients in Vermont that Dr. Smith had prescribed ketamine to via telemedicine. The committee selected 4 patients from that list and obtained their charts from Dr. Smith, and they were sent to an expert to offer her opinion about whether the care he provided to these patients met the standard of care. The expert who reviewed the cases is a psychiatrist who is board certified in psychiatry and neurology, and as part of her job oversees an interventional psychiatry program that includes ketamine treatment. And after her review, the expert concluded that Dr. Smith failed to meet the standard of care for prescribing ketamine for the treatment of depression for all 4 of the patients whose records she reviewed. The committee attempted to reach a negotiated agreement to resolve the case, and they were unable to reach an agreement with Dr. Smith. And so, as I mentioned briefly at the beginning, the board can impose discipline based on the Ohio board's order without the necessity of a contested hearing. And because the discipline that the committee deemed appropriate in the case is essentially the same as that which was imposed by Ohio, the committee decided to request that discipline be imposed under the compact rather than filing charges and going to a contested hearing in order to avoid incurring the time and expense associated with those proceedings. And so now I'll just real briefly talk to, or maybe explain a little more detail how the compact works in this particular situation. So Ohio has taken a disciplinary action, and it's determined that his conduct of having his license suspended by the DEA and then subsequently surrendering his license, both of those constituted unprofessional conduct under Ohio's law. Because Ohio and Vermont are both compact members, the board is able to impose discipline under the compact rather than having a contested hearing under the regular proceeding process. Ohio's law provides that the DEA's termination of a physician's prescribing privileges is unprofessional conduct for which the board can limit, revoke, or suspend a license. Vermont law also permits such discipline. Ohio law provides for the particular misconduct that Dr. Smith engaged in. Ohio's law requires a civil penalty of between $4,500 and $20,000. Vermont's law is different in that regard. What our statutes provide is that a monetary penalty can only be assessed of $1,000 per violation. So in this case, where there were two violations, the suspension of his license or his privileges by the DEA and then his subsequent surrender, the Vermont board could only assess a penalty of $2,000, not the $4,500 that Ohio did. However, similar to Ohio, it can assess a penalty. So with respect to the request to order that Dr. Smith not be permitted to apply for a Vermont license ever again, there's some overlap with the compact about why this request is being made. So the compact provides that a physician is ineligible to obtain a license through the compact if his license has ever been disciplined in any state. So by virtue of Ohio disciplining Dr. Smith, as well as the DEA's actions, he can never obtain a license through the compact in Vermont or any other state. However, he is still eligible to apply for a Vermont license under the regular process. So if the board were only to revoke his compact license, he could come back and apply for and potentially obtain a regular Vermont license. And so in order to reciprocate the discipline that Ohio imposed, which was a permanent revocation of his license, the board is being asked to include a prohibition of him applying for a regular license so that he is effectively permanently revoked from practicing medicine in Vermont. So after completing this investigation and considering the nature of unprofessional conduct that the Ohio board determined that Dr. Smith had committed and the sanctions it imposed, the Central Committee recommends that the board deem the Ohio board order conclusive as to the matters of law and fact that it decided. And it recommends that the board impose the following reciprocal discipline pursuant to the compact. Number one, that Dr. Smith's license be revoked. Number two, that he be permanently prohibited from applying for or obtaining a Vermont medical license, and that he be ordered to pay an administrative penalty of $2,000. Now, if there are any questions or clarifications you would like, please feel free to ask.
Do board members have questions for Mr. Kuehl?
Yes, I do. My question, Kurt, and probably Central Committee, is that we have physicians with Vermont licenses that have, their substance use and abuse and not and unprofessional conduct, but they're not completely, their license is not permanently revoked. I just want to know why. I understand the compact, Kurt, that was great explaining why we wouldn't give him that chance as Vermont, because he will have to apply specifically to our board to get a license and not through a compact. Is it just that the information from the ketamine disposal was so egregious? I mean, we know Matthew Perry died from ketamine. It's definitely deadly consequences and a lot of opioid overdose and misuse. But I just wonder why we wouldn't give him that chance.
The expert's report was very critical of his prescribing. He relied on diagnoses from other providers across the United States. He never spoke with them. He didn't seek out the records of their underlying conditions. A couple of the patients, for example, were on buprenorphine or methadone. He didn't seek out information about that. It's concerning to be prescribing ketamine and opioids at the same time. There was the dosages, for example, that he prescribed exceeded the limits of what should be prescribed based upon the weights of the patients, possibly because he didn't take the weights of the patients. So they were the expert's report was pretty critical, and so that was the reason for the request for the permanent revocation and prohibition from applying. Now, with that being said, there is a provisions in Vermont law that even if the board were to order this, Dr. Smith could always come back and he could ask the board to relieve him, to be relieved from that permanent revocation and allow him to apply. Now, he would have to get that permission, but he can make that request. So even though, unlike maybe some other states, in Vermont, even if we make a revocation permanent, a licensee can always come back and ask for another shot.
Okay, I understand like what your expert report was, and the high dosages. Those are not things that are new to us with a lot of the with a lot of our physicians we see, but we send them to programs to go to school to get CME, and those are all actions that can be corrected. That's why I'm still hung up as to why the permanent revocation. But I understand what you're saying.
I think, and I don't want to speak entirely for the committee here, but, another factor was that Dr. Smith was a family physician. He doesn't have any training in this type of medicine. It's something he, as he explained in the Ohio proceedings, took up because of circumstances in his personal life. And he felt it could be something that, could be a great treatment for people that was being underutilized. And he was not doing it well. He was doing it literally across the country in a very dangerous manner. And he was doing it to Vermont patients as well.
All right. Thank you.
Mr. Tucker, did you have a question?
I did. I think Kurt circled around and answered it. I was confused between the revocation through compact, and then you said a permanent revocation. So I think you explained it for me. Thank you.
Dr. Odeji, did you have a question?
I think I just had a comment. I think I was going to lean towards what Margaret said earlier on, that I think this is more of a very harsh punishment for him. Why don't we give him a chance that even if we revoke it through the compact, down the line, if he wants to come to the licensing committee for a license, then we can litigate it there. I think that's what I feel. Because this arose from Ohio, right?
The order was from Ohio. Dr. Smith lives and practices in South Carolina.
Okay.
Essentially, what happened is that, once the DEA took these actions against him, all the states where he was notified were, or all the states where he's licensed were notified of the DEA's actions and began taking actions against his license. The vast majority of the states, he just surrendered his license, and the state said that's good enough. The committee, however, had requested charts of patients he had treated in Vermont, and determined that he was practicing unprofessionally and potentially putting Vermont patients at risk, and didn't feel that it was appropriate to simply let him surrender his license and walk away without there being any record or notification to the public of that.
Last question, Kurt. He doesn't have a DEA license anymore, correct?
As far as I know, he doesn't.
Thanks.
He may, though. He may have gotten it back. I don't know.
Any other board member questions for Mr. Kuehl? Ms. Filbert? You're muted, ma'am.
Your Honor, would it be possible if he chooses to apply for a Vermont license in the future to review his license application, but limit his practice so that he's not prescribing ketamine and other and opioids?
Yeah, it would be up to the licensing committee. If you're suggesting, could the order state that if he, I suppose, and I don't know if this is what you're intending, but if it is, the order could be crafted in such a way that said, if he should apply for a Vermont license in the future, it shall be conditioned to prohibit him from prescribing controlled substances. If that's where you're going, that would be a possibility.
Mm-hmm. Clarify for me, controlled substance. I can't
those are
remember.
Controlled substances. It's a list of drugs from
right.
the
No, I
DEA
know what it is.
Oh,
yeah.
Yeah.
But the category 1 through 4, which is the most severe?
1. Those are the heroin and cocaine
High
and
risk.
stuff.
Okay.
And then as the drugs go down, I think their potential for abuse and becomes lesser as the schedules get higher.
But they're all considered scheduled. I mean, scheduled drugs or.
Yeah, they're scheduled drugs because the FDA has determined that they're subject to abuse.
Okay, thank you.
Yeah.
Mr. Herlihy, did you want to speak?
Yes, I want to make clear I'm not speaking as an advocate, but just an observation that may help to answer Dr. Tando's question. I just point out that this is a case in which the committee engaged in extensive negotiations with the respondent and did not arrive at an agreed result. The vast majority of the cases that you see where you're comparing it to where the board has agreed to some CME and maybe a financial penalty and some other lesser sanctions have been in cases where the respondent admitted their wrongdoing and negotiated to a discipline, whereas this has been imposed because of a failure to arrive at a negotiated discipline.
Thanks.
Is it a failure because he didn't show up, or he just chose not to? That's what I'm trying to get to, because I mean, this is not usually. And I'm not advocating either. It's just a point I wanted to make, and an observation, I should say.
Yeah. No, we negotiated for several months, 3 or 4, and I can't really go into it'd be inappropriate for me to go into the negotiations, other than to say we couldn't get an agreement from Dr. Smith.
Dr. Hildebrandt, did you have a question?
I just want to make sure I heard correctly, Kurt. So even if we were to vote to revoke his license and prevent him from ever applying again, he could still apply again by requesting permission to do so?
Well, yes. First, what would he'd have to do? He would have to come back and request the board to relieve him of the permanent prohibition of applying. And if the board considered that, said, okay, you are relieved of that, you can now apply, then he could apply, and it would have to be considered by the licensing committee.
And that would be something like he provided evidence as to why we would do this, not just request it, or how does that play out?
Yeah, well, I mean, he doesn't have to present anything, but if I were his lawyer, I would say, you would have to give them a reason why.
Okay. Thank you.
Patricia King, did you have a question?
Yes, this isn't about what you've just presented, but about this email we got for today. Have you seen that?
I have, yes.
I'm just confused about one thing.
Sure.
And that that Dr. Smith writes that seems to indicate he's prescribing in Vermont currently. It's in the second to the last paragraph, where he states, I even treated a Vermont physician that after they fully recovered, adopted my exact treatment, utilizing at home sublingual ketamine as part of their practice. So that physician is using it in their practice. Okay, great.
He raised this during the investigation and said, hey, look, your expert may think I was doing a bad job, but I treated a Vermont doctor doing this, and now he's doing what I did. So
okay. Thank you.
Dr. Eiler, did you have a question?
I just wanted to make a comment for the record. It was mentioned that he was a family physician and therefore didn't have training in this area. And there is a course regarding how to use ketamine that's open to physicians in any specialty. So his being a family physician would not be relevant. However, his practice patterns would be.
Other board member questions or comments? So, Mr. Kuehl, I had a quick question for you, and it has to do with the difference between the first motion for reciprocal discipline and the second, the amended one. So the first one asks for the respondent's license to be revoked and pay an administrative penalty of $2,000. And then the amendment added in the third point, which is the prohibition from applying for or obtaining a medical license. If someone had their license revoked as was proposed in the first, and then they applied for a Vermont license, would they not have to disclose that they had lost their DEA privileges and that they had been disciplined previously?
They would indeed.
So isn't that doubling up your paragraph C in the amendment to say that they're prohibited from applying? As you just pointed out, they're really not if they ask for permission to be relieved of that. And in any event, if they filed an application for a Vermont license, they would have to go through the disclosure of prior discipline, would they not?
They would. One point about what you said, Your Honor. So there are two types of licenses in Vermont. There's a compact license, and then there's the regular license. He had a compact license. When the compact license is revoked, he can never get one of those again, but he can still get a regular license. And because the discipline that was imposed by Ohio that we're asking the board to reciprocate was a permanent revocation, if he still has the ability to apply for and obtain a regular license, the revocation of his compact license doesn't affect a permanent revocation.
I guess it seems to me duplicative to say that he could not, he's prohibited from applying for or obtaining a medical license when if he tried to do that outside of the compact, he would have to disclose his history and it would come before the licensing committee. They would scrutinize his past behavior and the record. I mean, we would have a record of it. I just am wondering if the first sanction that was recommended, I'm asking you, wouldn't that be adequate?
I would say not entirely adequate if the goal is to prevent him from practicing in Vermont again, because it's unknown what a future licensing committee may do, how they may view the revocation of his compact license. And so the prohibition against him applying for a regular license is, again, one, intended to reciprocate the discipline imposed by Ohio, but also to send a message for future licensing committees, so to speak, who may not have the knowledge that the current board members do of the severity with which the board considered his conduct to be.
All right, thank you. Dr. Hildebrand, I see you've got your hand up again.
Just more, I guess, an observation. It seems as though the two places in which the full details of this case were available, both the Ohio board and our own internal committee, found this individual's behavior to be so egregious that it warranted permanent revocation. I think we should take that into consideration because obviously, as we know, we hear a abbreviated snapshot of what's been going on in the case.
Dr. Odeji, did you want to speak?
Yeah, just a quick question, maybe comment. So are we trying to take his license permanently because he failed in terms of the standard of practice? Is that why?
That is. But there's a rub to that. And this is the action under the compact. It's based on what Ohio did. And what Ohio did was revoke his license because of the DEA's actions.
Correct.
The committee determined that their primary focus was on his treatment of Vermont patients. Now, in order to establish what our experts said is that his care was substandard, would require the time and expense of a hearing. Because the disciplinary goal of the committee was to achieve the same result that Ohio did, the compact offered a more efficient and cheaper means of achieving that goal.
So last question, it says it was investigated by the Ohio Attorney General's office. Was that for the prescription or? According to it, they found his practice noble or something from his letter.
Well, the Ohio Attorney General's office was, like me, was the prosecutor in the board, before the board, the Ohio Medical Board. Okay. And the Ohio Medical Board permanently revoked his license. So I don't think they found it admirable, despite maybe his characterization of it.
Because it says, they described my medical practice as noble, see attached. And I don't know if you guys saw that on the, I think it's the,
yeah.
It says, I think the fourth paragraph, after exhaustive testimony of the Ohio Attorney General, it was their opinion I had not done anything that would merit the revocation of my medical license. and he described my medical practice as noble.
Well, I can't speak to what he may have spoken to the Ohio Attorney General's office about it, but the board order and the records show that the Ohio Attorney General's office prosecuted the case before the Ohio board, and the Ohio board permanently revoked his license. So I think, well, I won't speculate where he got his information, but the bottom line is the Ohio AG's office prosecuted him and attained a permanent revocation of his license. I would doubt that if their office's position was that his action was noble and professional, that they would do that. So I won't speculate further about why he would have said that.
Dr. Tortolani, did you have a question?
Yeah, thank you. I almost put my hand down because what Rick said is basically what I've been thinking is I have to put my faith in the fact that this case has been studied very greatly by the Central Committee, and they felt very strongly about their position. So I go with that. We don't have everything. We don't have all the information they had, and I'm going to go with what the Central Committee felt. Thank you.
Patricia King, did you want to speak?
Yeah, just briefly, again, to reiterate what Rick and Bob have just said, I think the other point is to take note that Central did try to negotiate a settlement. We don't know what those negotiations involved. They could have involved CME and other monitoring, as Margaret had mentioned, is often what we do, but there was no ability to come to a consensus in those negotiations. So again, kind of believing that Central did their best efforts in trying to negotiate a settlement.
Dr. Tando? You're muted.
Oh yeah, let me be clear that I wasn't questioning the work that Central had done. As a matter of fact, when I heard it, I was like, oh, this will be a quick case. We'll just go along and it will be over with. And this is the most discussions I've had in a hearing since I've been on the board. So I just wanted to, it was just not our usual pattern. And so, there's definitely more, that we don't know about, but I wasn't questioning what Central had come up with.
So are there any further comments or questions for Mr. Kuehl? So at this point, I would be wondering whether there was a committee member who made a motion. If they make a motion and there's a second to the motion, there will be an opportunity for discussion before we take a vote. But at this point, unless there are further questions or comments, I would ask, is there a motion regarding the pending matter?
So let me see if I understand this. And I'm going to make a motion. So I move that the permanent revocation that the committee approved in line with the compact that we agree with. Is that right? Is that right, Kurt? Because this is permanent revocation along the compact line of the license.
Yeah. So what the committee recommended is that the order revoke Dr. Smith's license, permanently prohibit him from applying for a license, and assess a $2,000 penalty.
Okay. Yes, that.
I'll second that, Philibert.
All right. Is there any discussion regarding the motion? If there's no discussion, and if you're ready for the question, I would ask Mr. Hunt to call the roll. And when your name is called, please vote yes or aye, no or nay, or abstain or recuse?
Rick Hildebrandt,
Yes.
Evan Eiler,
Yes.
Suzanne Jones,
Yes.
Pat King,
Yes.
Stephanie Lorenz,
Yes.
Ian Otagy,
Yes.
Don Philibert,
Yes.
Judy Scott,
Yes.
Margaret Tando,
Yes.
Bob Tortolani,
Yes.
and Scott Tucker.
Yes.
Did I miss anybody that was eligible to vote? No.
All right, thank you, Mr. Hunt. So the vote is unanimous. Mr. Kuehl, there was no proposed order, but I assume that you can prepare an order for Dr. Hildebrandt's signature along the lines of the amended motion for reciprocal discipline.
I will do that, Your Honor.
Great. All right, unless there's something further, that concludes that matter. Thank you all for your time.
Thank you.
Thanks, George. Appreciate it so much.
Okay, bye-bye.
Thank you, George. Take care.
George.
All right. We've already done our other business, so I think next would be to move to executive session, and I would propose that maybe we move to do so and then take a few minute break to stretch our legs, and then we can go into executive session. That sound good to everyone? Great.
I move executive session. Philibert.
Great. Can I get a second?
Second. Short.
Okay. We had a couple of seconds there. Any discussion? All in favor, say aye.
Aye.
Any opposed? No. All right. Move over to executive. We'll see you around 2:00.